Good afternoon, everyone. Welcome to our June CHIPS Method Seminar. So today we're super excited to have Dr. Chunqing Lin. She is one of our own. She's an assistant professor in residence in the Department of Psychiatry and Biobehavioral Sciences. And today she's going to be presenting dissemination and implementation of evidence-based interventions, multidisciplinary approaches, and we have till 3 o'clock for Chunqing to share this with us. So, welcome.
Thank you, Jay, for the introduction.
Sorry. Before I forget, Chunqing has asked me to pass out the teaching activities. So, emerging professors like us, we require evaluations from colleagues. So, feel free to fill it out right now. Or later. But yeah, actually appreciate it if you can fill it out.
Our prediction initiative.
All right, go ahead.
Sorry, I have a cold, so excuse me for my voice. So I was very fortunate to be awarded a K award to study implementation science of healthcare delivery in hospital systems. So today I'm going to share what I've learned from my K award and my research. So just Okay, so first of all, what is implementation science? So as we know, there is a huge gap between what is already known and what is applied in healthcare system. So every year, NIH devotes a lot of money to develop new interventions, and a lot of them have demonstrated efficacy in clinical trial settings, but very few of them have been actually used in healthcare services, so that reduce their impact on people's health. So implementation science study the process to promote the transfer of evidence-based intervention to real-world settings. So it's also known as dissemination and implementation research. So as the name implies, it has two aspects. One is dissemination, one is implementation. For dissemination, it studies how to spread the evidence-based intervention models to your audience, and then to promote the adoption and use of those intervention models. And for implementation, it studies when intervention is adopted in a healthcare settings, how to make it move more efficiently. So today I'm going to use two studies to demonstrate both aspects. So before I move to my studies, I would like to point out some of the characters of implementation research. So first of all, it's being conducted in real-world settings. So this is different from most randomized control trials, which is conducted in laboratory settings, where most of the agencies are very adherent. So this is not possible in implementation research, which focus on real-world settings. So also implementation science lies in different stage of intervention delivery, from exploration, design, installation, implementation to scale up. So it's a very wide spectrum. And also you have to consider multi-level factors from policy, organization, provider, and technology, etc. And it also focuses on process instead of outcomes. Instead of just measuring the magnitude of change, you need to focus on how and why the change takes place, so that you have to make use of qualitative and mixed method to investigate the challenges, barriers, and facilitators. So, and also the last thing I need to point out, because this is a new field, so we borrow some concepts and methods from multidisciplinary field, say for example economics, social science, marketing, and public policy, etc. So today the two studies I presented here are both using multidisciplinary researches. So, so the first study I present here is about dissemination of evidence-based intervention models. So my specific question is that when evidence-based intervention model is here, how do hospital stakeholders make decisions to adopt it or not? So in order to study this this question, I use conjoint analysis. So conjoint analysis is a statistical technique used in market research to determine how consumers, when they make a purchase, how do they evaluate different features of a product. So it has been used in study individual health behavior. Say for example, Jay and Scott here use conjoint analysis to study the acceptability of vaccines. So the advantage of conjoint analysis is that when you ask people like how important a feature is to influence your decision making of buying, then people say, oh, all these features are important, but oftentimes you have to make trade-off decisions. So let me just give a simple example. Say, for example, you are buying a hair dryer. There's many features that you have to consider. Say, for example, like price, if it has 0 voltage, if how powerful it is, and then the weight, noise level, and heat settings. So there are, say for example, like 3 different models in the market you need to consider. One is Dyson. It's very expensive, $300. It doesn't have 0 voltage. It's very powerful. The noise level is also high, and it has 3 heat settings, but it's expensive. And there's a Panasonic, which is half the price, but not as powerful. But it has 5 different heat settings. There's a T3, which is less expensive, not so powerful, but it has 0 voltage. So it depends on your individual need. You will make a choice among these combinations. Say for example, if you are frequent international travelers, you will probably choose T3 because it has 0 voltage. That's the most important feature to you, but may not be the same idea for other people. So using any questions so far? So just using this idea.
So when you go back to that, I think for conjoint analysis, so if you ask each of these characteristics separately one at a time, it's pretty, like the inherent preferences are pretty straightforward. So obviously people will prefer like $100 versus $300, and then people like lighter weight, and people would like less noisy hair dryer. But then when you combine it as a composite, people have to make decisions on which features are most influential in terms of making the decision.
And this was a motorcycle noise level. Some people like it really loud.
Yeah, say for example, at least you wake up very early in the morning, so you prefer the hair dryer to be less noisy. So it depends on individual needs. So apply this concept to evidence-based intervention models. We treat evidence-based intervention as a product and treat hospital stakeholders as a consumer. So to model their preference and decision and then features, and there's we call it attributes here, and then we need to generate some scenarios, a combination of the features. Then you present these features to your to the stakeholders and ask them to rate the acceptability, and then you collect their feedback and then conduct data analysis. So I will go over in detail. So I use evidence-based intervention model, which is developed by Dr. Lili here as an example, to study the intervention adoption. So the intervention is called, just a little background, it's called White Coat, Warm Heart. It's conducted in 40 county hospitals in 2 provinces of China. The main purpose is to reduce HIV-related stigma and avoidance to HIV patients. And the intervention is that we identify and train some popular opinion leaders in those hospitals to disseminate stigma reduction messages and also provide universal precaution supplies. So the outcome is significant. The intervention hospital demonstrated reduced prejudicial attitude and avoidance towards patients living with HIV. So the paper is published in the American Journal of Public Health. So we use this model as an example to study the adoption of this intervention model. So we conduct literature research and then in-depth interviews with some hospital directors to identify the factors that are most influential in their decision making to adopt this model. So we identify 7 factors that's most influential, including if the administrative support is available, and the cost, and the personnel involvement. Say, for example, what percentage of provider in the hospital need to be involved, and the format, whether it's flexible, whether it's online or in person, and the duration of the training, whether it's short or long, and availability of technical support, and if the stigma reduction is aligned with their hospital priorities. So that's 7 factors. And to reduce complexity, we assign 2 levels to each of the 7 attributes, preferred level and the non-preferred level. Say, for example, cost will be high versus low, and administrative support will be yes versus no. So because 7 attributes and 2 levels each will generate 128 possible scenarios. That's obviously impossible to administrate. So we use fractional, factorial, orthogonal design to reduce the combination to 8. So it's realized using a SAS macro, which I present here. The output looks like this in the table. So in accordance to the output, I generated 8 different scenarios, which is presented here. Say, for example, the first scenario represents the intervention model has minimum administrative support and relatively cheap, involves 50% of the provider in the hospital, short-term training, like 1 month, and then the format is flexible, it's internet-based, and the availability of technical support is maximum, and reducing stigma is not a priority in the hospital. So there are 8 different scenarios.
What was the last column there? The last column, I didn't understand it.
Oh, so if reducing stigma is a priority in the hospital.
You mean at baseline or something? Is that
No, there's no baseline. Say that
the policy is.
what is the current policy?
Yeah.
This is an intervention and the goal is to change
this big.
Right, so that's the goal.
Right. But if there's no institutional support in terms of the hospital, it's not their priority to address or providers different types of people. So it's just a dichotomy, I guess.
Okay.
So different health settings has their own priorities, their own agenda. So some from the in-depth interview, some stakeholder may say, oh, to make profit is my main priority in our hospital. And some other hospital, they have priorities such as protection of service provider safety, so that for those hospitals, stigma reduction is aligned. The intervention, evidence-based intervention model is aligned with their priorities.
So I guess where I'm a little confused is that the first columns, the first 1, 2, 3, 4, 5, 6 columns, seem to be attributes of the intervention, whereas the last column, if I understand it, is more an attribute of the setting that the intervention would be applied to. Do I have that right?
Yeah. I would say if the intervention is a fit of the organization. Yeah.
Yeah, I'm glad you added. It seems like maybe a way to think about this would be that you have, instead of 1, 2 to 7 design, you have stratified. You have 2 different settings, and you have 6 treatment factors. So I mean, there's still 128 combinations, but it's like that's maybe what you were getting at, is that there are 6 factors under the experimenter's control.
And the last one is really
sort
the
of
setting that it's being applied to.
Stratum.
Yeah.
Stratified factor. The part of what I was going to ask is, with only 8 combinations, it seems like I love the idea of doing a fractional factorial design as a general strategy, but with only 8 combinations, it seems like even all the two-way interactions would be confounded. It would just be that you have just estimates of main effects.
Right.
Correct.
Yeah, I think one thing to use this fractional factorial design to reduce the respondent burden, because it's impossible for them to rate more than 8 scenarios in person. And then later on, because we also collect feasibility data, and then some of the respondents do bring out that some of the combinations doesn't really make sense to them. So I was in later slide, I would suggest in the future we need to use a combination of both mathematical methods to come up with the scenarios and combine with the real world meanings. Because say for example the last one, the group section format with long duration could not be cheap. So that doesn't make sense. So in the future we need to use both mathematical method in combination with the real world meaning.
Right. So reducing it to just 8 scenarios, is limited to just estimating just the main effects only, and we're not looking at the interaction. So just to add to what Chunqing was saying, I think oftentimes we start out with this, with potential attributes, and then after this initial finding, we find out some of these attributes may not be as important, and we can reduce from 7 to say like the 3 attributes that are most impactful, and then we can do more combinations with different types of interactions.
So the participants are 60 hospital directors recruited from different level and different types of healthcare settings. Say for example, a third from provincial level, a third from city level, a third from county level, and some are general hospital directors, some are specialized hospital directors, and then 10 of them actually participate in the original what is called one-part intervention. So those hospital directors has to be 18 years or above, of course, and being a director or deputy director who has decision-making power in the hospital to participate. And we explained that it's research, it has nothing to do with their work. So they provided informed consent. And so the scenario was administered in a one-on-one face-to-face format. So the interviewer introduced the purpose, design, and the outcome of the WW intervention first, and then present the 8 scenarios in 8 answer cards. And then for each of the answer cards, the hospital directors were asked to rate their acceptability from highly likely to adopt to highly unlikely to adopt. Highly likely as 5 and highly unlikely as 1.
So just one question I have. So the outcome variable that you're collecting here is that last one, acceptability to adopt. It would seem to me that one of the major points for someone to make a decision is, does the scenario work? Like, does this intervention, what is its effectiveness? And what is the evidence that it actually works? So if I was making a decision, I'd want to say, like scenario 3, I'd want to know, well, how likely is this to work compared to scenario 1? Because I might be more inclined to favor a scenario if I have higher confidence it's going to work, and a measure of its effectiveness. So how does that factor into this?
So we trained the interviewers to present the intervention model in a standardized way. So they introduced the intervention model and then said that it demonstrates the effect in 40 hospitals, and the effect size is this and that. So given that effect size, how would you like to accept it, given the combination?
So going in, you're saying, we know these all will work at the
all
same level of effectiveness.
Yeah.
Kind of a related question. So this was done at the beginning to help design the intervention. So it seems like a really
No, it's after
a
big randomized controlled trial.
I think Ron's question is pretty good, but at the same time, I want to point out in the real world, actually those directors, some of them don't really have our mind that evidence base is good. They're more care about their practice, their environment, their staff, their hospital. So there's a question if we want to say this is the evidence base, it works. What do you think? So that seems like a pretty simple, for us it's pretty simple evidence, but not for that population. That's how we discussed to have some more practical issues there, led them to make a choice.
Yeah, so I think there are 2 different things. So whether you're interested in, the idea is it going to be effective or not? Is it going to work? But then there's also this disconnect between their preference and perception and whether it's going to work. So like the hypothetical vaccine acceptability study, it's probably not possible for us to have 90% efficacious vaccine, but that was one of the choices. So if they prefer, I'm only going to take the vaccine if it's 90% efficacious, and that's their preference, then in reality we're not going to have that. So there's a disconnect between their expectation and the reality. So the idea is we need to provide that level of education to feel that to bridge the gap between what's real and what their perception is. So hospital directors, based on this study, might say, yeah, this is going to be really helpful for our hospital, but this isn't really a priority for us. So instead of doing like a 90-minute session, I want to just do a 30-minute session. So I think that exercise is kind of important in terms of how do we implement the efficacious intervention in a real-world setting, and what are the factors that contribute to the success or failure of implementation.
So these are the answer cards. Each answer card presents one scenario with a 5 points rating, acceptability rating. So the data analysis, I use a mixed effect model. and to fit the acceptability rating as the outcome, and the 7 attributes as independent variables in the model. So because the 8 ratings are clustered in one respondent, so this model includes a respondent level random effect to account for the clustering effect within the respondent. And then the regression coefficient of each attribute is actually the impact score of the attribute on acceptability. So the outcome looks like this. So actually the cost is the most influential factor on their acceptability, followed by duration of the training, technical availability of technical support, flexibility of format, and other 3 factors, administrative support, personnel involvement, and then priority rating did not reach statistical significance. So in terms of feasibility of using conjoint analysis on adoption of evidence-based intervention models, the majority of the hospital directors reported that the format of data collection is clear and easy to understand. It takes about 10 minutes for them to complete the conjoint administration. So it's feasible, I think. And the advantage of comparing this conjoint analysis to other traditional priority rating method is that it provides more scientific rigor to quantify the relative importance of each feature of the intervention, and also it offers potential to using simulation models to predict how hospital directors would adopt certain evidence-based intervention models. And then also it, because I use a real intervention as an example to study this issue, so it has realism, and then the 8 scenarios allow side-by-side comparison. But there are several issues to consider when using the conjoint analysis in the future. So one thing is, if we want to use a real-life evidence-based model versus a hypothetical model, so I would say the real-life model provides more realism. Some of our participants actually participated in the original WW intervention, so they have more subjective aspects for this model. But hypothetical model may allow more generalizability to other types of evidence-based models. And the second thing is that if we want to specify the level of attributes, say for example the cost, we didn't specify whether the cost is like 500 per person versus 200 per person, because different hospital directors may have different perspectives on those amounts. So we just generally say expensive versus cheap. And the second thing is that we already mentioned this before, that we cannot purely rely on mathematical methods. We need to consider the real-life meanings of those scenarios generated by the model. And the fourth already mentioned too, that the interviewer has to present the model in a very standard way to avoid bias. So this is the first part of the first study that I want to present. And the second part is about...
So just one question. So based on your findings, what was your recommendation on those impact scores?
Impact scores?
You know, out of 7, there were 4 that were significant. So so what's the recommendation for hospitals going forward?
So obviously when you develop an intervention, you have to consider the costs, and you have to design the intervention in a way that's flexible in terms of format, and not too long, and provide continuous technical support to the target settings.
So the conclusion is the other three are not as important?
Yeah.
People in administration.
Okay, so I don't think
That was a go through.
So,
Did anyone pepper you with a question about multiple comparisons issues here? Like the three of them look like they would survive any kind of probability adjustment, but that fourth one format, it's like it might be a borderline, some multiple comparisons adjustment.
Former here I use internet-based versus in-person.
No, but I'm talking about purely the statistical significance question of whether, I don't know if this comes up in this context that much, but it's very common to be view of a paper for medical or public health journal. You've done 7 significance tests.
Oh, it's in the model.
I know, but you didn't do anything.
One thing that strikes me about this is that it almost seems like this analysis, which is very useful, should actually come before the studies are done, that this actually feeds into the design of an intervention, because if it comes out, and everyone wants things to be cheap, but if it comes out that, hey, look, we can't afford anything that's going to cost more than this, then that's constraint, and that actually feeds then into the development of acceptable interventions rather than the other way
I think
around.
you're absolutely right. So this will be useful in terms of how you scale up what's been proven for the next step. So going forward, hospitals can use this data to adapt the evidence-based intervention to fit their setting. Yeah, exactly. Okay.
So, say for example, the original intervention is 3 months. Given this data, it might advise you to maybe shorten it, maybe to lower the cost. Obviously, provides insights for future intervention development. So this is the first study. So the second study question is that when evidence-based model is adopted in a certain healthcare settings, how to improve the efficiency of service delivery. So one example is that we treat the service delivery as a process, which defines as a series of logical connected activities and steps. Say, for example, so every task can be defined as a process. Say, for example, you are making a beef noodle. It involves these many steps. This will add up to 25 minutes. Well, it actually costs 25 minutes. The answer is no. If you design the process carefully, you can actually perform some tasks simultaneously to reduce the total processing time to 14 minutes. Right? So, for example, when you are boiling the water, you can prepare the beef and then some scallions, and then once everything is prepared, you cook and you add some other ingredients. So the minimum time of processing is 14 minutes.
You say microwave.
It takes 2 minutes for me.
I will show you a cartoon later on. And so apply this concept to healthcare delivery. I use the concept to study the delivery of prevention of mother-to-child transmission of HIV. So it's already proven that ART is very efficacious to prevent mother-to-child transmission of HIV. However, it's less effective among migrant population in China. So using this concept, I want to find out why and where is the problem and how to address the problem. So PMTCT can be considered as a long process from the first antenatal care visiting to HIV testing to prophylactic ART delivery, infant feeding follow-up, and then family planning to long-term HIV care. It's a long process. So first of all, I need to figure out how the process is like. So in order to do that, I conduct a first round of focus group with 10 service providers and 10 healthcare administrators who are involved in the process. They include the OB doctors and ART doctors and CDC doctors and Center for Women and Child Center doctors and then family planning doctors and all the different parties involved in the process were invited to the focus group discussion. So I asked them what are the steps a pregnant woman need to go through in order to receive a complete prevention of mother-to-child transmission services. So start from the first step. For each step, I ask the responsible parties, and then I draw a diagram, and then on the whiteboard, and show the diagram to them, and ask if the diagram is correct and complete. So the diagram looks like this. So it's called a cross-functional flow chart. It has different responsible parties on the top, including Center for Women and Child Health and other healthcare facilities and CDC-affiliated hospitals. And then the tasks of being responsible for different parties are listed underneath in the swim lane underneath it. So with this flowchart in hand, I conduct an in-depth interview with 20 recently delivered migrant women with HIV, and I present the flowchart to them and ask them to point out which steps they perceive to be most challenging and what are the specific barriers for each of the steps. So then I identify the challenges in specific to different steps. Say, for example, the first step, the first antenatal care visit, represent the most barrier here because for migrant women, they have very limited knowledge about antenatal care. They don't know when and where to start and how to start antenatal care. So this is the first challenge I identified here. And when they get into the system, stigma and then insufficient communication with providers is the second challenge, so that they tend to avoid reduced antenatal visit and also try to deliver their baby in a different hospital where the doctors don't know their HIV status. So this is the second challenge here. And the third challenge is that after delivery, the baby are followed up by Center for Women and Child Health, and the pregnant woman, the postpartum woman are followed up by CDC-affiliated AIDS clinics. So they had to go to multiple appointments to take care of both them and the baby. So it presents a burden here. And the fourth challenge is that although there are some preferential policies, say for example, the pregnant women are provided for free vouchers for 4 free antenatal care visits, and the postpartum women are provided 3,000 Chinese yuan for their formula feeding. Some women did not know there are such policy and did not know where to obtain those vouchers. So these are 4 challenges. So I bring back these challenges, report by pregnant women, and then had the second round of focus group with service providers and health administrators who participate in the first round, and then debrief those challenges reported by the migrant women with HIV, and then I guide them to revisit the service flow chart and then brainstorm if anything could be done differently to improve the process. So we actually came up with some solutions to tackle each of the challenges. Say, for example, for the limited knowledge of antenatal care, the service provider decided that they would expand the health education effort to include not just the pregnant women but all reproductive age women and their husbands. And for stigma and lack of privacy protection, those providers said they are going to enhance the privacy protection and service provider training in hospitals. For the follow-up baby and mother in different systems, they said right now it's challenging to combine these two systems or to provide one-stop shop, but it's definitely important to enhance communication and collaboration between these two agencies. For lack of information on those available preferential policies, they are going to try to use some mobile-based knowledge dissemination tools to disseminate the policies. So this is just an example that using the process mapping and examination tools, we can come up with very specific service gaps and very targeted solutions as compared to traditional qualitative methods. So, and then this exercise this time is conducted by me as a researcher from outside, but I think through the process, the healthcare professionals kind of realize there is a service gap between So I would recommend that they can conduct this exercise by themselves to identify if there is any gap between their practice and the national guidelines. So actually, the process mapping can do much more than what I presented here. Say, for example, you can collect qualitative or quantitative data to identify the system bottlenecks and the system weights. Say, for example, you can calculate the throughput, which is the ratio of input and output for each of the steps. So the step with the lowest throughput will be the system bottleneck. And then you can also calculate the between steps delay and then the one with the longest waiting time. And then calculate the monetary, personnel, and time costs of each steps. These are the system bottlenecks. And then for system waste, you can calculate the defects, errors, and the variabilities associated with each step. So the steps with most errors will need standardization or retraining. And then also you can examine if the patients and the materials have been moved unnecessarily in the steps, and also monitor the accountability and collaboration between the multiple parties involved in the process. This can be done in future studies. So with those qualitative and quantitative data in hand, you can actually redesign the process or modify the process to improve the efficiency. So, for example, you can simplify and remove some unnecessary steps, and so combine with some tasks that's been done by multiple parties. And then if some steps are being processed in a very inconsistent way, then you can standardize it. And also retrain the steps with most errors. And also you can examine if any tasks can be performed by a lower level of healthcare professionals. So just to save expertise, to decentralize the expertise. So and also just want to point out that this process enhancement exercise can be done at multiple levels. So the study I just presented is conducted in agency level to investigate the collaboration between agencies. Within agency, you can also examine the collaboration between different teams. Within teams, you can study the at interpersonal level, the collaboration between different team members. And within each individual, you can examine your performance. Say, for example, if you have wasted a lot of time finding things, doing unnecessary movements to enhance your own proficiency. So also, this is a continuous process. You define the problem, measure the problem, analyze the process, improve the process, and retain the process. Then you can start all over again. It's a continuous, never-end process. So just want to provide some reference of implementation science in general and control analysis and process examination. And the second study I presented here just got online today, so I just include that link here. And then that's all. So just want to acknowledge the funding source and then collaborators, and Lily is my mentor, and then Dr. Sanjay to provide the idea of conjoint analysis. So that's all. So this is my favorite cartoon. The process, but not so much.
Thank you.
So we have a few minutes for questions.
Maybe I'll start just as a, like I said, the use of a more sophisticated experimental design framework, this fractional factorial design, which would be a general strategy for accommodating lots of treatments when units are expensive to come by. I mean, that's very appealing as a general idea. I'm just wondering if you could elaborate on how you see that kind of a strategy being more broadly relevant in AIDS prevention. Well, I mean, the conjoint analysis also is interesting as a strategy for evaluating treatment combinations. I don't know, just maybe generally commenting on how you see those strategies being useful more generally for AIDS prevention.
So I think the process enhancement strategy can actually be used in a broad spectrum of research. Say, for example, screening management, and then for anything, not just HIV/AIDS. So as I mentioned before, that it can be used at multiple levels, and from agencies to individuals. I use a lot consciously to improve my efficiency doing things. And then at team level, it used to monitor the performance of individual team members and to monitor the collaboration of different teams, and then it can be used in a lot of different areas.
Yeah, I think I like the idea of process mapping, and I think for whether it's for HIV prevention or treatment, we've come with this whole framework of this treatment continuum, and I think each process has many different facilitators and barriers, and I think each agency implements those strategies rather differently. So I think it'd be very useful to kind of. So I think the challenge is to come up with a process mapping that's accurate, right? And then figure out what are some of the bottlenecks and barriers, and then based on that improve how we deliver care.
And you have to figure out the process in a greater detail. Sometimes it includes feedback loops, and then so that you can identify exactly where the problem is, and you figure out the target ways to tackle the problem.
So, great presentation. A couple of things came to my mind as you were talking about the process mapping. And one that kind of bubbles up the first is that it depends, process mapping, you can have the same agency and you would end up with different process maps depending upon whether you were a consumer, whether you were a frontline staff, or whether you were in the administration and executive parts. How do you put those three different sorts of, or there may be more, how do you put these different sorts of understandings of what's necessary and what's not necessary together to come up with a coherent conclusion?
So the second study I present here is actually indirect communication between service providers, policymakers, and consumers. So actually the two groups of service providers, focus group are conducted separately with service providers and healthcare administrators. They have different perspectives. But so the two flow charts that come out from those two focus groups are actually a little different. So I draw a final flow chart which incorporates the different steps from the two focus groups to come up with the final flow chart, and then I present the final flow chart to the service provider and then policymakers again to make sure it's accurate and every step is necessary. Then I conduct in-depth interview with the pregnant women and users, and then they obviously they are not very familiar with some of the steps, but for those steps they are aware of. They can point out the specific challenges with the steps they have experienced on. So it's you need to talk to different group of people to have a overall view of the project.
Also, I think that adaptation is a really important piece now in the research field, because there's so many interventions already in the field, and you don't have to reinvent the wheel all the time. But in the meantime, is there a way to adopt the intervention to different settings? I think people really just do their own thing. It's really hard to bring up something like to summarize in kind of process to really, be used by others and try. So I think that's the first study about, because in our another paper for our outcome of the intervention, we find out even intervention work, but those 20 hospitals in the intervention arm, they have different outcomes. They all have positive outcome, but their outcome at different level. So that actually motivated Chunqing to go further to see, let's look at those hospitals. If there's something, even we think we deliver the intervention the same way, but there's other things in the field we don't know. And that may be some factors that we need to consider. So this is the background of why we're doing it.
Well, even in the same setting, the policies can change so quickly.
Exactly.
Like Sean has found out with Facebook and that home and health space, or now agencies don't want to recruit in waiting rooms anymore, so we cut out that whole part of it.
It's really hard, and but people try.
Good job.